Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and teaching you about the human heart illnesses and its awareness. So welcome again on the social channels. We are featuring on social media. And without any further ado, I'd like to delve into the subject matter. And this is bradycardia part 2. We're going to be discussing today. Bradycardia 1 was already, I guess you have already seen or watched my video earlier. That's the earlier vignette where I talked about the high-grade AV blocks. Now here we're going to be talking about mostly the sixth sinus syndrome. What is sixth sinus syndrome? We call it SSS. So the sixth sinus syndrome implies normally there is a bradycardia component to it and there is a tachy component to it. So the bradycardia component where the heart rate is extremely slow, so it could be a normal sinus rhythm, but the heart rate is less than 60. As we know, the definition has to be less than 60 in order to qualify for bradycardia. And most of these rhythms are sinus, so you'll still say that they are sinus rhythm. And then in the tachycardia part, there may be atrial fibrillation, we call it AF, or it could be atrial flutter. So either of the two or the combination of the two could be present as well. Now, atrial fibrillation or atrial flutter, they will all have a high ventricular rate. That's very, very typical of this. So when you have atrial fibrillation with a high ventricular rate, automatically it compromises on your ejection fraction, on your stroke volume, and as a result, the cardiac output diminishes because of the rapidity of the ventricular rate, like 150, 175, and that's certainly not compatible with life for too long, specifically if it exists like that, or it can degenerate into even a very rapid rhythm. So obviously this is a very, very symptomatic and a very dangerous rhythm, so this needs to be treated. So normally what happens is when you try to treat a sixth sinus syndrome in the presence of atrial fibrillation, because that's where the patients will be presenting with. They'll be presenting with dizziness, obviously. They'll be presenting with significant palpitations. Dizziness because of the bradycardia and palpitations because of tachycardic symptoms. So these two and significant diaphoresis, etc. Most of these patients are elderly, so they're past the age of 70 or 75, if you will. Normally the etiology is, again, either it's fibrosis or degenerative disease, and so that's commonly seen in these individuals where either there is a sinus rest that can be seen at times. There could be sinoatrial block, or there could be sinoatrial exit block, if you will, or there might be just a reduced atomicity, just like a sinus bradycardia, if you will, just a heart rate less than 60. So atomicity is reduced. So either of these etiologies will be resulting into this kind of a sixth sinus syndrome. We call it a sixth sinus because the sinus is sick. Now, having understood this part, so therefore the fibrosis and degenerative, these are the common causes, and atrial fibrillation with a rapid ventricular rate, so that needs an attention. So how do you treat that? So ventricular rate needs to be slowed down. So you can reduce that by certain drugs like beta blockers. You can use calcium blockers, if you will. And if you use the calcium blocker, both these drugs, they will require to reduce the positive ionotropy, and therefore the heart rate will go down, no question. But what happens is during the time when this patient is having the bradycardia and the tachycardia syndrome during the day, the drug does not disappear during the time the bradycardia occurs, obviously. The drug persists throughout the day. So when it persists throughout the day and the bradycardia event was to occur, like the heart rate goes down to less than 60, suddenly that heart rate in the presence of a beta blocker or calcium blocker could be devastating. So therefore you require a pacemaker as well. So here comes the VVI. So VVI type of a pacemaker will be very helpful because that will work best for atrial fibrillation with ventricular rate which is very rapid. So what you could do is you could have a pacemaker placed in this individual where you could give a beta blocker to control the ventricular rate, but a pacemaker will immediately kick in should the heart rate drop below 60. You see? So you have a combination of the two that will work best in sixth sinus syndrome, and that's what I wanted to discuss in this quick video vignette here, because it's a very, very important entity. It'll be on the boards, both for internal medicine and cardiovascular. Again, we are discussing the basics of sixth sinus syndrome here, not getting into the intricacies, but just so that you understand the principle here is you want to give a beta blocker, but not at the expense of causing more bradycardia or significant bradycardia, even if the patient was not that symptomatic with that. Now, all of a sudden, the heart rate may drop below 60 and go to 40 or 50. So you're better off giving a pacemaker, which will automatically kick in and be set at the heart rate of 70 71. So say anything less than 71, automatically the pacing will begin. Whereas if it goes too rapid, then you have a beta blocker and calcium blocker on board. You follow? So those are some of the things that you will see will continue to have as symptoms. Now, very importantly, one should also understand that the complete heart block, which we have not had a chance to discuss in our part 1, and here is your complete heart block, that will be definitely on the boards, and of course, one encounters even in day-to-day clinical practice. So again, my favorite schematic is right here, if you will. Here's your right atrium and right ventricle, and this is your left atrium and left ventricle. So now implying that SA node is here, AV node is here, and then you have a complete heart block. That means now the bundle of His is, or the His is totally separated from the AV node. So now the atria are contracting regardless of what the ventricular rate is. So they're complete AV dissociation, if you will. So there will be an AV dissociation. Atrial rate is obviously more than the ventricular rate. And atria are independent to the ventricles, rather. Yeah, the A waves are independent to the ventricles. That means the P waves are independent to the QRS complexes. So here the EKG will be, clearly showing that you have P waves. For instance, I'll draw the P waves first, for instance, here, just for the sake of the clarity. Now this P got conducted, for instance, so you'll have a P which was, the P is not getting conducted in a complete heart block, so you'll have a QRS somewhere here. And now the QRS is going at a slower rate, so obviously it's here at this rate. And then you have a QRS here, which may be actually right over the P wave here, and then a QRS comes in here. So you see how they overlap even on the P waves. So there will be an AV dissociation here, as we call it. And obviously the P's and the QRS's, there is no relationship at all. So normally the atrial rate could be, say, 75, that's the A rate, and then the ventricular rate could be about 35 to 40. And so this is very, very symptomatic and requires a pacemaker. So normally a DDD type of a pacemaker is offered to these individuals because you do have sinus conduction. So you're better off giving a DDD, which is a dual pacing, dual inhibition, and dual a dual demand inhibition and pacing for entire pacing mechanisms for this pacemaker that's been offered. So just be mindful that AV dissociation, atrial rate more than ventricular rate, and then of course atria beating independently of the ventricles. Those are typical features of complete heart block. Again, do not forget the etiologies, which are reversible. Obviously, sometimes it's ischemia, sometimes it's an infarct, and of course infarct sometimes in an inferior wall setting. It may be only transitory. You may just give a temporary pacemaker, but if it's an anterior wall, then obviously it's significant, and we'll be discussing that in several other videos that have been discussed. Lyme disease, this is treatable. Again, you treat that with the antibiotics. And then, of course, cardiomyopathies, of course, that becomes, normally complete heart block of significance, and therefore that will require permanent pacing as well. So these are the other causes besides the degeneration and fibrosis which we talked about here. So in a nutshell, we have looked at 6 sinus syndrome, which is composed of bradycardia and tachycardia, and it's also called brady-tachy syndrome, where the tachy is composed of atrial fibrillation and atrial flutter, if you will. But again, beta blockers and calcium blockers to slow the ventricular rate, but then at the same time you need a VVI pacing to control the bradycardia that can ensue during the time when somebody is bradycardic, also during the 6 sinus syndrome episode. And likewise, for complete heart block, you will require pacing, and that is something which is very, very important. So one does understand that is a given, that you require DDD type of pacing, because there is a complete AV dissociation existing in these complete heart blocks. Again, I once again thank you for your attention on MuniMeterHealth.com. This is your favorite website, which is educating you and teaching you. Our goal is to improve the clinical outcomes by combining medical education with patient education. Once again, thank you for watching MuniMeterHealth.com, and do send your comments, like your buttons, and make sure to give your suggestions and questions, etc. And spread the word, of course, and share with your colleagues. And so long, this is Dr. Sharad Jaitly. Bye.